So our next presenter is Dr. Scott Weingarten. I'm pleased to have him here. Thank you.
Thank you, Avram. It's really an honor and a pleasure to be here today. Dr. Torrens is my mentor. It really transformed my life, a large part of the reason I'm here tonight, and really my hero in many ways as a healthcare leader, as a teacher, and as a gentleman. So I really appreciate the invitation to be here today. So I'd like to share with you a few thoughts about MACRA, and I want to take you to Cedars-Sinai, a little bit east of here, and the chief of staff, Dr. Eng, said, we need to invite our medical staff and educate them about MACRA, and let's have an evening meeting. And I said, Chris, it sounds like a good idea, but will our physicians really show up? And he said, let's see. And so we invited our physicians to the large auditorium, and it was packed with physicians who wanted to understand what this fundamental transformation in healthcare reimbursement really was about. And about halfway through the presentation, a physician raised, in this case, his hand and said, well, wait, we're going to have a new president next November. Will that change everything? And I shared what Ashby shared. I said, well, I don't think so. And I really don't, because it overwhelmingly passed. With bipartisan support. It passed in the Senate by a vote of 92-8. In the House by a vote of 329-37. Can you think of any other bill that passed by that margin? That means Democrats voted for it. That means Republicans voted for it. And it means when there's a new president in November, the fundamental principles are likely to stay the same. So the way that I describe the environment to my colleagues, physicians at Cedars-Sinai, in some ways, it's like this bridge. And probably many of you do not recognize this bridge. Anybody recognize the bridge? You do. What bridge? Okay. I guess not. Okay. So this is the Chola Teka Bridge. And it's over the Chola Teka River, and it's in Honduras. And back in the 1930s, the government of Honduras wanted to, they wanted to build a state-of-the-art bridge, and they brought in the U.S. Army Corps of Engineers, and they envisioned a day when there would be many more cars than there were at that time in the 1930s in Honduras. And the bridge was really an engineering marvel, civil engineering marvel. And then in 1998, a catastrophe hit Honduras, and some of you may know what it was. Anybody know? Yes, it was Hurricane Mitch. It was a Category 5 hurricane, 180 mile-an-hour winds off the Atlantic, one of the largest hurricanes ever to hit the Americas. And then everybody went to bed, and the next morning they woke up and they inspected the bridges, and many of the bridges were damaged or destroyed. But how about the Chola Teka Bridge? It was fine. But what no one saw coming is that the hurricane moved the river from over there to over there. Bridge to nowhere. And so if you look, in many ways, the American healthcare system was designed for volume. The more fill in the blank we did, the more revenue. And it's been transformed. The river's been moved to value. So we'll talk about what the implications are for health systems and for physicians. And so this means, as I think Ashby described quite eloquently, health systems and physicians are going to be at risk for cost, quality, patient experience. It's causing health systems to fundamentally rethink the way we align with physicians, the way we align with other providers, the way we think about the continuum of care, other legislation such as CJR, sometimes called bundled payments for hip replacement, knee replacement. We need to reach out and align with skilled nursing facilities, home health agencies, to be successful, deliver the best possible quality of care at an affordable cost. And with any fundamental disruption in any industry, including healthcare, it's likely there will be winners and losers, those that are able to adapt to these significant changes in the financing and delivery of healthcare are going to succeed, and they're going to thrive, and they're going to do well. But there perhaps are some that'll be less successful. in adapting to all of these changes. And there are implications for physicians, many implications. Because, again, to be competitive, as we heard about MIPS and alternative payment models, as physicians, we're going to need to compete on quality, satisfaction, and cost. And the world has changed. You have information technology, and we're rapidly entering what's been called the post-EHR era, where physicians in their office have an EHR that may not be interoperable and often isn't interoperable with another EHR. And how do we exchange vital information that's critical for patient care? And what layer of technology is going to sit on top of the EHRs? We need digital health initiatives. A lot of venture capital is being deployed to create digital health companies. Virtual services. We've been offering at Cedars-Sinai, in some cases, e-visits, where patients will log on to their portal and describe their problems over the internet, and the physician will respond fairly quickly. Very convenient for patients. They love it. Satisfaction rate's extremely high. Why? They don't need to, in many cases, they don't need to get in their car, they don't need to park, they don't need to sit in a waiting room. We did a pilot on video visits. Patients can stay home. They don't feel well. In some cases, quality of care can be quite good. You have data analytics, care management approaches with care managers, seeing patients in their home, team-based care. And for physicians, where are a lot of physicians going to get this access to this infrastructure and the investment that's required to build this infrastructure? It's going to be a challenge in the future across the United States. Now, as we look at these fundamental changes across the country, we're aligning. Hospitals are aligning with physicians. And this was an interesting survey that just came out from the advisory board, where they polled 160, what they call C-suite executives across the United States. And they say, what is the most important factor that will determine organizational success for systemness if you get alignment of hospitals and physicians and physician groups? And they looked at that and they said, clinical standardization. The most important factor. It's also the hardest, but the critical factor for success. So, and if you think about it, as health systems get bigger, that a patient who has a PSA, who enters the system in one place, should probably receive the same information to help him determine his care as if he entered the health system in another place, right? Both parts of the system have access to the same scientific evidence to help inform that patient about what is the optimal care. So how do we promote this clinical standardization as part of delivering value of care? So let me finish up and just share with you a story about my favorite football player. Anybody know who this football player is? What team is he on? He's on Seattle. It's a sharp group. All right, he's on Seattle. So the player, he's a former Bruin. Does that help? No? Okay. You need a little more help? He's not a physician. His name is Derrick Coleman. Okay. So Derrick Coleman is deaf. Okay. And they said, you can't play on your high school football team. You're deaf. You can't hear the plays called in the huddle. You can't hear when the referee blows the play dead. He's an offensive player. You can't hear the footsteps of the defensive player. And guess what? He was a star of his high school team. And they said, okay, that's fine. That's high school. It's one level. Okay. You can't play football in college. And he was recruited by UCLA. And are there any UCLA football fans out here? I'm one. Anybody remember Derrick Coleman? He was good. He was really good. Tailback. Okay. He overcame these obstacles, and he was really a star. UCLA football team is tailback. And they said, okay, that's college. But you can't play in the NFL. Whole nother speed. It's different in the NFL than it is in college. And what's he wearing? I'll give you a hint. On his ring finger. Super Bowl ring. And those of you Seattle fans probably think he should have 2 Super Bowl rings. But we won't go there. And people asked him later, he said, you've told your whole life you can't play football because you're deaf. What did you think when they told you that? And he smiled. He smiled again. He said, I couldn't hear him. Couldn't hear him. So as we try to transform healthcare, and I'll bring you back to Cedars for a second, it is challenging. It is hard. If it were easy, everybody would do it. Deliver high-quality care, value-based care, clinical efficient care, a great patient experience. But I think, thanks to a great team of people at Cedars-Sinai, that I try to stay out of their way, and hopefully I'm successful in staying out of their way, they've been delivering great quality of care and also much more efficient care, along with the great quality. So, for example, in Cedars-Sinai Medical Group, and I see Tom Gordon out there under his leadership, Cedars-Sinai Medical Group now has admission rates in the what's called well-managed Milliman, best 5% according to Milliman, and that's by delivering more care in the home, care management programs. Also, one of our health plan partners, one of our valued health plan partners who's actually represented in the audience, 34% reduction in year-over-year inpatient utilization. We're seeing shared savings from health plan ACOs. Again, some really good work under the leadership of many people who work for Mr. Prysolak. A medical surgical length of stay index in the best 20%, 20th percentile, a little better than that, among academic medical centers with very good readmission rates, very good quality of care, and then significant reduction in costs and improvements in quality from clinical decision support, form of clinical standardization. So I thank you very much for your attention.